Hamstring strain. The song in the background you're hearing is by Kingswood. It's called Golden. Fantastic song. One of my favorites, actually. You got your hooks in me. All right, so let's go ahead and get started. So hamstring strain, what do you have to know? Well, number one, it's quite a common injury, actually. So what do we get? So stretch or partial tear or full tear, actually, of the hammies. So biceps femoris, semitendinosus, semimembranosus. And you get a tear through the center of the fibers or the musculotendinous junction, wherever it is. People will know this right away. Most often occur in activities where the hamstrings are stretched. And usually you're going from a full eccentric to concentric contraction when this happens. So the muscle gets all the way stretched out. They try and push off. And as they push off, they feel the tearing. And I'll give you two examples from my own life. So number one, my dad, when I was growing up, we were moving a semi-truck battery. Now, just so you know, the size of a semi-truck battery, it's usually twice the size of a car battery. And literally what he was doing was he had the battery, he was carrying it in front of him like this, and he was leaning down with his back straight, and he was taking the weight like a straight leg deadlift through his hamstrings. And he actually felt the muscle tear in the back of his hamstrings. And that's how he developed a hamstring tear. For myself, I want to say, oh yeah, it was jiu-jitsu. I was fighting with this guy. He got me in a knee bar. I tried to pull out of it, couldn't get out. Nope. I was being my usual idiot self, and we were playing tennis. This is actually when I was in school. And I go to my wife. I'm like, hey, I think I can toss my leg above this fence. And so I do a lot of stretching. I can usually get my feet above my head, no problem, in a front stretch. But this fence was a little bit higher. And so I said, I can kick my leg up there, no problem. And you're going to see what I'm wearing here for everything. But so what do? I take my leg and I go to kick it up, shablam. And sure enough, I got it up there, fully centric load. And all of a sudden, instant pain into my one hamstring. I walked around with a limp for the next 2 months because I tore the back of my hamstring, kicking it way up there, kind of beyond my limit, basically. So those will be two examples of how those actually take place. Another common place that I see it on patients is I have a number of FIFA level referees that I treat. And these soccer guys, you have to be fast as a ref. So they got good running speed and everything. But one of them, he came in and he had just black bruising all over the back of his leg. Seeing his physio, and his physio had him doing banding exercises to lightly push into it. And we'll get into the treatment here in a little bit, but we got to get people better faster. So we changed our treatments a bit, but back into the basics here. So demographics, most common strain of the lower extremity by far, 16 to 25-year-old, but can occur at any age. Most common in athletes. Eccentric contraction is what you're looking at there, or eccentric concentric. Looking at ballistic type movements, so sprinting, soccer, football, hurdles, dancers, those are your prime examples right there. Prior hamstring injury and failure to warm up are the number one causative agents right here. Could also be secondary to the activity that they're doing with the quick stops. The research is controversial if weak glutes and all that, but you have to think if the hamstrings have to take more load and it's not being done by other muscles that should be taking the load, you're going to be more likely to damage that tissue, assuming your body hasn't had time to adapt to it well. You're going to want to have a good hamstrings to quadricep ratio if possible. Of course, just physical fitness in general is going to improve overall ability. The weekend warriors are where we tend to see this, or middle-aged people commonly as well. Prior injury and return to activity too soon. And I cannot stress this enough, pun intended. Do not get back to activity too soon, at least high-level ballistic activities. Start off moving. Definitely manual therapies in the area are going to offer a lot of benefit, but you want to work a little bit lighter earlier and make sure that you have full healing before you give that super hard run and then just wind up tearing it again right away. Often these injuries can take months to heal. So for the patient's history, onset of posterior thigh pain, rarely will they hear a popping. Like the example I gave for my dad, he actually felt it tear apart. And he said there was like a sucking sound in the back of his leg, back of his thigh is what he meant. And yeah, that was the muscle physically tearing apart, okay? Injury usually occurs at the end or beginning of an activity. So if you're fatigued or if you haven't warmed up enough, or that transition eccentric concentric, there will be pain whenever you use your hamstrings. That means going upstairs. If you sit in a chair and the damaged tissue gets compressed, you're not going to like it. All right. Physical exam, possible antalgic gait, especially as the injury is more severe, and ecchymosis and bruising. Don't be tricked though. Usually where the bruising is lower than where the injury is, just because gravity lets it kind of pool down a little bit lower in the fascial planes in the back of the thigh. What else do we have to see here? Palpation. Yes, tenderness to palpation. You can usually roll right over top of this tissue, no problem. And then you can often palpate the defect. And when I felt this on myself, on my dad, on my FIFA soccer refs who've had this, and players, you can palpate the defect and the person jumps off the table. They give you that jump sign. It is tender. It is a tight muscle. Okay. Depending on exactly which muscle it's in. Active range of motion, passive range of motion, usually not too bad unless the injury is quite severe, but I would recommend you start with a straight leg raise, not as a test for radiculopathy, but as a test to go ahead and see how they actually have for their flexibility and how it changes over time, how much range they have for their flexibility. And of course, this would be a prime example where a muscle test should be done, and repeat that muscle test on follow-up visits to see how the person is evolving over time. Neurovascular issues are usually within normal limits. There are cases of hamstring tightness, possibly compressing the sciatic nerve. But if I was getting long track nerve signs, I would be looking for a coexisting radiculopathy or some kind of impingement, piriformis syndrome, whatever else it is. And of course, we have separate videos and all of that you can look at as well. All right, grading severity. Yes, mild, moderate, or severe. Grade 1, grade 2, grade 3. So mild, you can usually walk with no problem. Might be a limp, probably not. Definite pain with running or full stretch. You don't want to give those fast ballistic movements. Grade 2, now they're going to come in with a limp. They're going to resist full knee flexion or extension. They don't want to stretch it out. Painful altered gait and running is not possible. It'll just be too painful. And then a grade 3, this person might even come in on crutches. That's how bad it is. And full ruptures can occur. If there is a full rupture, I would strongly recommend a orthosurgical evaluation as well, just to make sure there aren't other treatment options available that might be better outside of your outpatient clinic. Differential diagnosis, and this is where I write this, should be obvious. Do not look for other things here. Well, I shouldn't say that. Look for other things potentially that may coexist. But at the end of the day, if you can't figure out someone's got a hamstring strain, you need to go back and review some very basic anatomy and content. So what do we have? Straight leg raise is where I would start. Again, not for sciatica or radiculopathy, but for stretching of the damaged muscle. And I would use this as an outcome marker. When you first came in, we could only lift your leg to 40 degrees of flexion. Now you're at 50. Next visit, you're at 60. Those are positive outcomes right there. Diagnostic imaging, usually not warranted. On ultrasound, you could actually see it. MRI would show you the extent of the tissue damage. But again, usually overkill. These things are often self-limiting. And because it's muscle tissue damage, it heals really, really well. Really good blood supply. All right, so general measures, what are you going to do? Key to successful recovery is recognizing the injury, severity, and stage they're at, and making sure to follow the appropriate healing protocols. So number one, for a lot of athletes, this can be a season-ending injury right here, depending on where they are and how severe it is. So biopsychosocial support is going to be key. Do they have the right support to continue their studies or whatever else they're into right now? Do they realize this is probably not a career-ending injury and they can probably recover from it? What else? Pain-free stretching and strengthening. The sooner I can get you moving, the better the outcomes are going to be. Agility and trunk training absolutely is going to be there. Potentially K-tape. I'm a big fan of instrument-assisted techniques over top of this as well. The example that I gave, and we'll go into massage therapy here, was not working acutely over the injury with the instruments to begin with, but into more subacute. Yeah, absolutely. And the exercises I gave for the last guy I treated with this, again, FIFA ref, basically, what did he do? He was been giving like little hamstring tubing exercises, and I think we can do better than that. A little bit of instrument-assisted stripping through the area. Was too tender on the first visit to go right into the injury site, but also eccentric loading. So something just as simple as keep your back straight, leaning forward like a straight leg deadlift or something like that with no weight to your point of tolerance. Second visit, which was about a week later, young guy, so he was probably already, well, young guy in shape, but he was probably already about 30% better on the next visit. And he's like, thanks so much for progressing me through. I've been stuck here for the last 3 to 5 weeks. What do you say? That was a 4-weeker, that one, I think. Regardless, you know how the patients get mixed up in your brain, but anyways, it was a winning treatment for him. Instrument assisted, joint play, passive stretching, all those are going to be wins to get you moving sooner. Joint mobs in areas of compensation, electrotherapeutics to maybe knock down the pain, acupuncture, diet and botanicals, surgery rarely indicated. And then of course we can get into our follow-up. Do not return to ballistic activities too early. If you come in too early, then you're going to be looking at re-injury. And just like a groin strain, this condition can become pathologic. What else? You want to work on stretching and strengthening those hamstrings. Strength with power is what you're looking for, okay? Strength with flexibility and power. Patients with tolerance may progress to agility drills and eventually activity-specific exercises. Again, the sooner I can get you there without injury, the better the outcome is going to be. Educate on risk factors. Did you warm up? Do you really have to extend your leg all the way out, or can you go a little bit shorter on the action so you don't put yourself into this injury zone? Are you doing the appropriate cool down afterwards? Do you have the right people working with you for your appropriate treatments all the way through your rehab process, pre-game, post-game, all that stuff? Also, let the coaches know too. These hamstring strains can go chronic and become significant injuries for people. Generally good prognosis for more minor injuries, more severe injuries. You can get more larger scar tissue formation that may be there for a longer period of time. But again, load it early for better outcomes. You have to load a tissue to heal a tissue. And the sooner I can get you moving, the better things are going to be. Acute injuries can lead to contracture of tissue and loss of flexibility. And this scar tissue rarely, but there are some cases of it, can compress on the sciatic nerve. If I'm giving you specific exercises in rehab, one of the ones that I like is just a simple stretching band like this. Literally, hook onto your foot, lift yourself up. Also good ones, what we call the runner stretch, keeping your legs straight. Even dorsiflexion of the toes might even add a little bit more to it. Excuse me. Just gently challenging the tissue a little bit more in a safe way to tell the cells which way to lay things down. As their strength builds up, a supported triangle pose could be good. Simple leg swings can get in there. Nordics can be good under a weight or have somebody holding your heels. Even better yet, these are one of my favorites in my regular exercise routine. Split leg, single leg deadlift like this, okay, is fantastic. Can be just body weight, can be 1 kettlebell, 2 kettlebells, whatever you want, but they all work as a gradual progression for graded exercise exposure. Gradual progression is what we're looking for. Again, you've got to load the tissue to heal the tissue. Hamstring strain, great condition. There's lots we can do for it. Can really help these people a lot reach their optimum potential. Cool. All right.